Assalamu alaikum wa rahmatullahi wa barakatuh. We will talk in this lecture and the next one about hemorrhagic disorders in pediatric. At the end of this session, you will be able to know how to approach to a child with a bleeding disorder through a key aspect of clinical history and physical examination, and through the laboratory investigations that are specific for diagnosis of bleeding disorders and how we can interpret the results. And we will discuss a common bleeding disorder in pediatric, acquired one like ITP and hereditary like hemophilia and von Willebrand. Let's start with this case of presentation. A 4-year-old girl was admitted to emergency department with the sudden onset of bruising, a generalized bluish scar rash, and a history of intermittent epistaxis for 2 days. Her family denied other symptoms, but states that she had a cold 3 weeks ago, and there's no previous same condition and no family history of a bleeding tendency. Physical examination was unremarkable, apart from the skin findings mentioned above. What is the problem of this child? Obviously, from the sign and symptom mentioned in this case, the child is suffering from bleeding tendency. So, what is the meaning or definition of bleeding? Is the susceptibility to bleeding or bruise easily due to disorder in normal hemostasis? And what is the meaning of hemostasis? Is an active process of blood clotting in areas of blood vessel injury, and over time this clot is lysed by the fibrinolytic system and normal blood flow is restored. Let's take a rapid revision for the normal hemostasis. And what is the steps of hemostasis? First step after vascular injury is vasoconstriction. This is the first step, vascular injury. The second step is the platelet plaque formation through the platelet deposition and adhesion, platelet secretion, and the platelet aggregation with the help of von Willebrand factor lead to formation of a platelet plaque, but it is friable, need to support it by which result from the third step, which is coagulation phase or coagulation cascade, through which there will be serial activation of clotting factor through the intrinsic and extrinsic pathway until the final step of common pathway where the thrombin activation from the prothrombin, and this thrombin will help in activation or formation of fibrin from the fibrinogen, and with the help of factor 13 lead to formation of a stable fibrin platelet plaque, and this clot with time will be lysed by the fibrin. So for the normal hemostasis, need a normal blood vessel, normal platelet number and function, and normal clotting factor. All these three help in formation of a stable fibrin platelet plaque that later on lysed by the fibrinolytic system through the anticoagulant antithrombin 3 protein S and C. So the first two steps of vasoconstriction and platelet aggregation called primary hemostasis, while the clotting factor activation and coagulation cascade called secondary hemostasis. Any defect in a primary or secondary hemostasis will lead to bleeding tendency, while if there is a defect in fibrinolytic system will lead to excessive clot formation and will lead to problem of thrombosis. So bleeding disorders is the result either from vascular abnormalities, platelet disorders, and clotting factor abnormalities. How would you approach to a child with a bleeding tendency? Of course, the approach always will be through the clinical history and physical examination, and then later on laboratory test. The clinical history is very important to provide us with useful information. So to evaluate a child with a bleeding disorder, the clinical history should determine the following: the sign or sites of bleeding. It is the skin, mucous membrane, joint, or muscle bleeding. The severity and duration of hemorrhage. Was the bleeding spontaneous or did it occur after trauma? And what type of trauma? Is minimal trauma or severe trauma? Did the symptom correlated with the degree of injury or trauma? The age at onset first attack of bleeding. Was there any increased bleeding after surgical procedure like circumcision, dental extraction, tonsillectomy, or others? In post-pubertal female, it is important to take a careful menstrual history. Was there a previous personal or family history of similar problems? If there is any chronic disease or chronic use of certain medication, like non-steroidal or anticoagulant. Second is physical examination. The physical examination should focus on whether the bleeding symptoms are mucous membrane and skin, it is mucocutaneous bleeding, or it is deep tissue bleeding, muscle and joint bleeding. The examination should also determine the presence of petechiae, ecchymosis, hematomas, and hemarthrosis. And what does mean these conditions? Petechiae or petechial sclerage is a pinpoint non-raised lesion less than 2 mm, like in the picture. While ecchymosis or bruises are larger area of 1 to 2 cm in size or more, like also in this picture. And this is ecchymosis, large, deep ecchymosis. Purpura is larger area, more than 3 mm, red to purple in color, and it is a group of adjoining petechiae. Hematoma is a localized swelling with elevated border, raised palpable ecchymosis. Hemarthrosis is bleeding in the joint, and this type of bleeding is deep tissue bleeding. How we can localize the hemostatic defect, whether it is a primary or secondary, and as we mentioned, primary means platelet disorder and the blood vessel, while secondary is coagulation factor defect. From the clinical manifestation, the site of bleeding, usually it is mucocutaneous in a primary hemostasis, while it is deep in soft tissue and joint and muscle. Petechial rash is usually common in primary hemostasis, while it is not in secondary. Ecchymosis, usually it is small and superficial, while it is large and deep in secondary hemostasis. Hemarthrosis is usually not occur in a primary hemostatic defect, while it is common in secondary. Hematoma is rare in a primary hemostatic defect, while it is common in secondary hemostatic defect. After history and physical examination, we will send for laboratory tests. And in patients who have a positive bleeding history, a platelet count, prothrombin time, and activated partial thromboplastin time should be performed as initial screening test. And in individual with abnormal screening test, further evaluation with a specific test should be based on the result of the initial one. The laboratory test will be start by complete blood picture looking for the platelet count, bleeding time, prothrombin time, partial thromboplastin time, thrombin time, and INR. All this is initial screening test. Will lead us to more specific tests according to the result, like platelet function, mixing study, von Willebrand antigen and activity, clotting factors assay, fibrinolysis test, and bone marrow study. This is more specific, not done as initial. It's done according to the result of initial test. And other specific test is a clotting factor assay, according to the result of a bleeding profile times. So we'll start by the platelet. The normal platelet count is 150 to 450 multiplied by 10 to the power 9. That's to say it's 150,000 to 450,000. Thrombocytopenia refers to a reduction in a platelet count to less than 150,000, while thrombocythemia is referred to platelet dysfunction. So the defect in number or function of the platelets will lead to bleeding disorder. And this is the platelet function, as we mentioned, deposition, adhesion, secretion, aggregation, all these consider function. Bleeding time, normal bleeding time is 4 to 8 minutes, and usually it's prolonged when there is a platelet disorder, whether thrombocytopenia or thrombocythemia. That's to say, defect in function or decrease in number. And also it's prolonged when there is von Willebrand disease. Prothrombin time and activated partial thromboplastin time, also it is initial screening test. Partial thromboplastin time, normal value 25 to 40 seconds, and it's prolonged when there is deficiency of intrinsic pathway factor 2, 5, 8, 9, 10, 11, and 12, in addition to common pathway defect. While prothrombin time, normal value 12 to 14 seconds, and it is measure extrinsic pathway activity, and it's prolonged when there is factor 7 deficiency and in common pathway defects. Common pathway defects lead to prolonged in prothrombin time and activated partial thromboplastin time and indicate deficiency in factor 1, 2, 5, and 10. Thrombin time is 11 to 15 seconds, and usually it's prolonged when there is deficiency in fibrinogen or dysfunction. We will talk in this lecture about thrombocytopenia, which means, as we mentioned, reduction in a platelet count to less than 150,000. And the normal platelet count is 150,000 to 450,000 cells per cubic millimeter. The decrease in number of platelets is result either from decreased production from the bone marrow, and this is either congenital or acquired, or peripheral destruction. Destruction either is primary, idiopathic, autoimmune, like in idiopathic thrombocytopenic purpura, or it is secondary to other processes non-immune like due to drugs, hemorrhagic uremic syndrome, HIV, DIC, thrombotic thrombocytopenic purpura. We will take a common example of thrombocytopenia in pediatric, which is idiopathic thrombocytopenic purpura. We will return to the example mentioned in the beginning. For this 4-year-old girl who admitted to emergency department with sudden onset bruising, generalized bluish sclerage, and history of intermittent epistaxis for 2 days. Her family denied other symptoms, but states that she had a history of cold 3 weeks ago, and there is no family history of bleeding tendency, and although the child has no previous same condition. Physical examination was unremarkable apart from the skin findings. That is to say, she has no other signs like lymphadenopathy or hepatosplenomegaly or fever. Lab test done for this child and revealed hemoglobin level 11 gram per deciliter, white BC 7,500 and normal differential count. And the platelet count is 20,000 cell per cubic millimeter. So what is the most likely diagnosis? When we look to the lab test that reveal normal hemoglobin, white BC count and differential, but there is low platelet count, 20,000, means there is a thrombocytopenia. With such history, the most likely diagnosis is ITP or idiopathic autoimmune thrombocytopenic purpura, which is the most common cause of acute onset thrombocytopenia in an otherwise well child. The peak age is 1 to 4 years, and there is history of recent or exposure to common viral infection about 1 to 4 weeks before develop symptoms. And in childhood, male and female are equally affected. The etiology or the pathogenesis. There is an autoantibody directed against the platelet surface and binds to its membrane. And this circulating antibody-coated platelet are recognized by the Fc receptor of splenic macrophage, lead to ingested and destroyed of this antibody-coated platelet, result in a thrombocytopenia. Exact mechanism for this antigenic target for such autoantibody formation remain undetermined. And this is the platelet-coated antibody recognized by the Fc portion of splenic macrophage that lead to phagocytosis of this platelet-coated antibody result in thrombocytopenia. What is the clinical manifestation? Usually abrupt onset petechial rash, purpura, and bleeding from gum and mucous membrane. That is to say, is mucocutaneous bleeding. Physical examination are normal, apart from signs of bleeding. That is to say, there is no anemia or lymphadenopathy or hepatosplenomegaly, just this sign of mucocutaneous bleeding. The diagnosis of ITP usually starts by sending the patient for CBC that reveals severe thrombocytopenia, the platelet count less than 20,000, while the hemoglobin and white BC count and differential should be normal. Bone marrow examination is another step for diagnosis of ITP, but it it's indicated in unexplained anemia, abnormal white PC count or differential, or when there is hepatosplenomegaly or lymphadenopathy. And the finding is increased number of megakaryocytes, which is the precursor of platelet, and some appear to be immature and is a reflect of increased platelet turnover because of peripheral. The treatment of ITP aimed to increase the platelet count to more than 20,000. To increase the platelet count to more than 20,000 to decrease the risk of spontaneous and life-threatening bleeding, which is intracranial hemorrhage that occurs when the platelet less than 10,000 cells per cubic millimeter. And the treatment, the line of treatment, all targeted against this destruction of the platelet-coated antibody by the macrophage of the spleen. And the first line of treatment is intravenous immunoglobulin in a dose of 0.8 to 1 gram per kg per day for 1 to 2 days that induce a rapid rise in platelet more than 20,000 per cubic millimeter in 95% of patients with 48 hours. Side effect: headache, vomiting that when occur suggestive of aseptic meningitis. Second line, it is oral intravenous anti-D therapy for Rh positive patients in a dose of 50 to 75 micrograms per kg, causing a rise in platelet count to more than 20,000 cells per cubic millimeter within 48 hours. And it is ineffective in Rh negative patients. Side effect: rare intravascular hemorrhage. The third therapy is corticosteroid therapy, prednisone, in a dose of 1 to 4 mg per kg per 24 per kg through 24 hours. Continue for 2 to 3 weeks with tapering of the dose to avoid the long-term side effect of corticosteroid therapy. If there is any indication for platelet transfusion in ITP, the platelet transfusion is contraindication unless in life-threatening bleeding, because antiplatelet antibodies bind to transfuse platelet as well as they do to autologous platelet, so will lead to more platelet destruction and more thrombocytopenia. What is a chronic ITP? When the patient with acute ITP who have persistent thrombocytopenia for more than 12 months are said to have chronic ITP, and it's occurring in 20%. And in chronic ITP should exclude secondary causes like SLE, HIV, immune deficiency, H. pylori infection, and others. And there is a different line of therapy used in chronic ITP, like intravenous immunoglobulin or corticosteroid or IV anti-D, or rituximab, or agent that stimulate thrombopoiesis, example thromboplastin. What is the role of splenectomy in ITP? Usually in chronic ITP in older children more than 4 years with severe chronic ITP, and for those patients with severe symptoms that not controlled by the therapy. Thank you. for listening, and the reference of this lecture is from Nielsen Textbook of Pediatric, Essential Pediatric, Illustrated Pediatric, Hematological chapter. And thank you very much. Any question? I wait for your question.